It's great to have back on the program today Dr. Isaac Bogoch, an infectious diseases physician and scientist based out of the University of Toronto and Toronto General Hospital. Great having you back again.
Great to see you again.
So, where to even start? Okay, I mean, over the last month or so, we've seen a global decline of about 30, 31, 32% in daily case average. The US has seen a similar decline. Some countries are a little bit ahead of that, some a little bit behind. What's the explanation here? Is it vaccination getting to a critical point? Is there still some seasonality we don't understand? Is it just inaccurate reporting and maybe cases aren't really going down?
Yeah, I think it's a lot of the above. In fact, all of the above. So certainly in countries that have significant vaccine access and vaccine rollout, that's definitely helping, right? That's definitely keeping cases down or driving cases down, and we can't ignore that. But of course, there's probably other factors at play. We know that vaccine equity, global vaccine equity, is a major issue. There still are billions of people around the world without access to these vaccines, mainly in low income countries. And there are, depending on where you are in the world, there are very significant outbreaks and epidemics of this. So globally, it's great to see those cases go down. I think it's too soon to start having, mission accomplished banners up or anything like that. We're still at a global level far from the end, but certainly in countries with high vaccine uptake, like the United States, like Canada, like many European countries and a few countries in Asia, yeah, we are closer to the end. We might be in the second to third period rather than in the first period, like unfortunately some other countries are.
So last summer of 2020, there was the correct belief that the fall into winter in the northern hemisphere was going to get pretty bad. At the time, we were just starting to roll out vaccines. There was very limited availability. The peak ended up being in the US, it was basically January 20th, right around presidential inauguration day. In other countries, it was a little bit earlier, a little bit later. And then we saw the sort of big decline, and then we got the Delta spike. This time around, where vaccination is available in many of these countries, and we're still not totally sure about the seasonality matchup that sort of mirrors the flu's seasonality. What do we think about this fall and winter in the Northern Hemisphere?
Right. I think there's a couple of points. One is that when we talk about seasonality, it might mean different things to different people. And yes, I'm sure eventually this virus will have a more seasonal component. Maybe it'll be more present in certain times of years, like the colder months versus the warmer months, and that's very likely to happen with time. But when I'm talking about seasonality now, I'm oversimplifying it, but it kind of can be simplified in the sense that whatever puts people indoors is a risk factor for greater transmission. Hey, it's cold outside and it's September, so kids are going back to school. Many people are going back to work in person, and we're not hanging out outdoors as much anymore because it's getting chilly. We're spending recreational time indoors, and that in and of itself at a population level can certainly drive numbers up because there's just innumerable opportunities for this virus to be transmitted. So when we put that together and look at the northern hemisphere, yes, it is getting cooler. People are going inside for more and more reasons. I think it's fair to say that we will see peaks and valleys, but probably peaks throughout the cooler months and the fall and the winter in the northern hemisphere. And it sort of stating the obvious, I think areas that have more widespread vaccine uptake will have more blunted peaks. So the amplitude of those peaks is really under our control in countries like Canada and the United States that are fortunate enough to have access to those vaccines. You can vaccinate yourself and those around you in your community. You can create safer indoor spaces as well with masking, with ventilation, with crowd control. Like there's a lot of steps we can take to create safer indoor spaces at a population level as well, so that you reap the benefits of those vaccination campaigns plus those non-pharmaceutical interventions. So short story long, yeah, I mean, we'll probably have some peaks and valleys throughout the fall and the winter, but how high those peaks go are under our control. We have the tools to keep this under control.
So, on speaking of tools, there was a period where it seemed as though every adult was headed towards a third shot. Originally, the word booster was used, but when the framing was no, 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 it may be a 3-shot regimen. The change of language was it's not a booster. It's just part of what you're supposed to do. And then all of a sudden, we started seeing a change in tone to some degree, where at least in the US, the recommendation changed to only third shots for 65 plus immunocompromised pre-existing conditions, which if you include being overweight and smoking is a lot of people in the United States, right? I mean, but let's put that aside just for a second here. What's your sense of, because there's the medical question as to who would really benefit. There's a vaccine equity question as to should people be getting third shots, or are those better used as first shots in other parts of the world? How should we be thinking about it?
David, I love how you separate those questions because oftentimes that gets confused. And from a medical standpoint, like this is a very valid medical question. Do people need a third dose of the vaccine? And if we want to delve into that, I think the answer is, like anything else, it's a bit more complicated. I think there's good data to drive that immunocompromised individuals, however we want to define it, would benefit from a third dose of a vaccine, right? They just don't mount the same degree of an immune response as other people. And as you point out, this can be viewed as, many people have had 2 doses of a 3-dose regimen. You need that third dose for better protection. We've known this for a million years, well before COVID-19, right? There's a reason we give immunocompromised individuals double doses of, for example, the hepatitis B vaccine. Like this is known. Similar to that, people who are on the older end of the spectrum will probably benefit from a third dose of a vaccine. In the United States, it was defined as 65 and up. We could argue and debate about the data, but that's not unreasonable, including those who live in congregate care settings like long-term care facilities. And again, we've known this long before COVID-19 came around. There's a reason we give older cohorts the higher dose influenza vaccine every year because we know they need an extra boost to mount an immune response. But I got to say, and when I'm sitting in Canada now, when we were listening to the United States discuss this, if we were in mid-August, we heard very senior political and public health leaders say, everyone's getting a booster shot at the 6-month mark. Oops, pardon us. Sorry, everyone's getting a booster at the 5-month mark. Oops, no, we meant 6 months or 8 months. And then they actually had to sit down and you had the FDA discuss it. Then you had the vaccine experts discuss it. Like the process to get to this decision was very choppy and I think did a lot of damage in terms of public trust in the vaccine efforts, especially when we know many unvaccinated people currently, we're, for lack of a better word, we're trying to win them over. We're trying to show and demonstrate how safe and effective and reasonable it is to get these vaccines. This didn't do a lot of good in getting to that point, unfortunately. The other thing too is, I don't know where it really landed in the United States because it seems like, if you're a smoker, if you're obese, if you may work in a higher risk setting, it basically seems like it's open season and anyone who wants to get a third dose can get a third dose. I don't think that's really appropriate. I'm not to blab on and on, but then let's factor in the equity issue. You've got hundreds of millions of people that are eligible for a third dose when there's billions of people who haven't received a first dose and hundreds or tens of millions of Americans that should be receiving a first dose. You want to get this under control, you get first and second doses in as many people as possible rather than third doses. Not to ignore that there are some people who would really benefit from a third dose. So to sum it all up, do we all need third doses now? No, we don't. Do some of us need third doses now? Yes, some of us do. Will we all need a third dose at some point in the future? Yeah, we might all need a third dose at some point in the future, but we don't all need a third dose now.
So in terms of protection level, which as you point out, can be in terms of larger populations, the protection level is lower for certain folks, and that's a factor in thinking about these third doses. How should we be thinking now about how protected one is today, given the difference between the dominant Delta strain and what was the original or live strain for which the vaccines were calculated? Because you hear you still got a mask if you're vaccinated because you can still spread it. And then you hear, hey, actually, you can, but if you're vaccinated and asymptomatic, it's not super likely, but it's possible, and it makes it very difficult to do like a risk assessment of any individual. So when you read 99, 98, 97% of the cases and or at least hospitalizations are in the unvaccinated, what does that tell us?
Yeah, basically, sometimes people complain about shifting goalposts and you're changing the rules. And the answer is yes. Of course, they're shifting goalposts. Of course, you're changing the rules and adapting policy. You have to because the virus has changed as well. And the Delta variant is, of course, it's the same virus, but it functions in a different manner. It's way more transmissible compared to the original virus that emerged from Wuhan. So yes, you have to have these shifting goalposts. The problem is communicating this and telegraphing uncertainty and communicating that there will be changes over time. Some we can expect, some we might not be able to expect, so that people don't feel like they're getting the rug pulled from underneath them. So that's one important point. The second point, though, is yeah, I mean, Delta is much more transmissible, but we do know that if you're vaccinated, right off the bat, Delta or not, well, especially even with Delta, you still reduce the risk of getting COVID-19. You reduce the risk of getting infected, but you greatly reduce your risk of getting really sick, like landing in hospital, needing an ICU, or dying. And there's just overwhelming data from multiple countries demonstrating all this. The second point is you can still get infected with Delta, even if you're vaccinated. We've known that. We've known that long before Delta even emerged. In the original clinical trials that were published, there were still vaccinated people that got infected. Delta hadn't even emerged yet. So that's not new. But we do know now that if you are vaccinated and infected, you're just much less likely to transmit to other people. Of course, you can still transmit, but the probability is lower. So, for example, if you want to create a safe indoor space, a restaurant, a bar, a casino, a daycare, wherever, the more vaccinated people you have in that indoor space, you just reduce A, the likelihood that you're bringing COVID-19 into that space, and B, if it is brought in, the likelihood that it's transmitted to other people. Of course, that's one significant layer of protection, but we have to think of this as layers of protection. There's other layers you can take: masking, ventilation, crowd control. And when you put all those layers together, and you add that to vaccines, you want to get really fancy, add rapid testing at the door. The more layers you have, the safer the indoor space you have. The more layers you peel off, you're just adding incremental levels of risk. And you've got to find that sweet spot of what's reasonable, what's convenient, and what's necessary for that particular environment.
Last thing I want to touch on: when do cases no longer matter in a very specific sense? I think it was with H1N1 that at a certain point, when it was determined that it's no more deadly than the flu strain of that year. And correct me if it's not H1N1, but it was a different thing that I'm referring to. At a certain point, the testing stopped because it didn't really matter whether you had the flu or you had, again, I think it was H1N1, because the protocol was no different. It was no more deadly. The case numbers may have been interesting, but they didn't really tell us anything about the risk to an individual of getting really sick from being out in the world. Does it depend on the level of vaccination? Does it depend on the maybe reduced severity of coronavirus as we go forward, which may happen or it may not? When do the case numbers no longer matter?
So I think if you lined up 20 people in the business, you'd probably get several different answers. The way I think about this, though, is I like the case numbers, but it has to be put into the appropriate context, right? There's a lot of data: hospitalizations, ICUs, deaths, cases, vaccinated, percent positive, blah, 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 blah. Context is important. So you have to put the appropriate weight and context to each data point. But when the case numbers sort of start to lower in the importance factor, I think in my mind, it's really when we start to see this virus not impact our society as much anymore. What do you mean by that? It's not resulting in an overwhelming number of hospitalizations or deaths or morbidity. It's not preventing people from doing what they do. And a lot of that's a value judgment as well, right? There's a value judgment here. It's kind of unfortunate and disgusting to think about, but at some point, we're going to have to collectively decide what is an acceptable number of deaths per year for COVID-19. Not nice to think about, but we have to figure that out. Like in Canada, for example, influenza kills 3,500 people per year. Awful, terrible, get your flu shot. All of them are tragic. But as a country, we've sort of come to terms with that's about how many we see per year. we have to come to terms with how many COVID-19 deaths or cases or what is quote unquote acceptable. And like, again, some will say zero. I don't think that's practical. Of course, there's the let her rip crowd. I don't think that's safe or ethical as well.
Right.
But eventually, enough people have immunity through vaccination or recovery from infection that it just doesn't pose a burden on the country or the region as much as it used to. You're not going to overwhelm your healthcare system. You can go to restaurants and bars and live your life, but the virus isn't going away. So it's going to be a bit of a value judgment. That's a bit of a long-winded way of answering that question, but at some point, as long as when it impacts the country or the region less by not overwhelming the healthcare system and not causing meaningful morbidity and mortality, that's probably when the case counts don't matter.
Yeah, and it will still be a different call for different individuals, also based on their level of risk and their willingness to accept risk as well. So it's a complex answer because it's a complex question, I guess, is the way we would say it. We've been speaking with Dr. Isaac Bogoch, infectious diseases physician and scientist based at the University of Toronto and Toronto General Hospital. Always great catching up with you.
Great to chat, David.